The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/UPA860. Downloadable slides and practice aids are also available.
Hello, and welcome to Charting Progress in AML Care, a clinical casebook on the intersection of novel therapy and allogeneic stem cell transplantation. I'm Dr. Gail Robos from Weill Cornell Medical College and the New York Presbyterian Hospital in New York City, and I'm pleased to welcome my colleague, Dr. James Foran from the Mayo Clinic in Florida. So, moving on to the agenda, we want to talk about some updates on novel induction and integration of targeted agents, talking also about antibody strategies in stem cell transplant eligible patients from conditioning to future applications, and also insights on maintenance strategies. And I think our real goal here is to talk about those difficult gray zones where transplant may or may not be the best choice for some of our both younger and older patients, and to figure out, again, how to use novel therapies, but still keeping transplant in the picture. So first, we're going to talk about novel induction strategies and integration of targeted and novel agents into standard AML induction. So if you look here at the updated NCCN guidelines for patients under 60, this particular slide is focusing on some difficult to treat patients. So we have the intermediate risk cytogenetics and FLT3 mutated patients together, and those patients with a FLT3 mutation would be eligible for standard doses of cytarabine and daunorubicin with midostaurin as the standard of care. The unfavorable risk at cytogenetics and Tp53 mutated patients remain very, very difficult to treat. And basically, whatever guidelines you look at say something like alternative induction, because we just want to do something other than standard 7 and 3 for those patients because outcomes aren't great, either with 7 and 3 or actually with transplant either. And then for the last group, for therapy-related patients other than core binding factor, those with antecedent MDS, those with cytogenetic changes that suggest an antecedent marrow disease, here we can use standard dosing schedules of daunorubicin and cytarabine, but there's also the option of liposomal daunorubicin and cytarabine, which has shown better outcomes for that particular group. But all of these groups remain challenging, and stem cell transplant is still often the post-remission choice for patients who are eligible. So what can we do to soup up the inductions and make them better, either to eliminate the need for transplant eventually or to optimize outcomes after transplant? So here, looking at the patients older than 60, transplant is often not a consideration at all. And you can look in the last part where they say the unfavorable prognostic factors. These are patients who may not ever be considered for transplant and who may go on to lower intensity therapies. But for some of the favorable risk, and even for FLT3 mutated patients, even in the older 60 group, we want to get access to novel agents, get them into a deep remission, and hopefully for some of those older patients still consider stem cell transplantation. That's really going to be the focus of a lot of this discussion. So looking specifically at FLT3 mutated disease, you can see a snapshot of FLT3 inhibitors here. We have midostaurin, which is approved. Midostaurin is a so-called dirty inhibitor. It hits lots of things, not only FLT3. That may be a good thing because it may have activity in other aspects of AML, but so far it's really shown the promise in randomized trials in FLT3 mutated patients, and that's where it's approved. Gilteritinib, which is a more targeted and potent FLT3 inhibitor, is approved for patients with relapse disease. And then we have quizartinib, sorafenib, and crenolanib, which are still actually figuring out how exactly to be used. Sorafenib is an approved drug, but not specifically for FLT3 mutated disease. So Ratify, which I referred to earlier, shows that if you add midostaurin to standard induction, you do better. And those that led to the approval of midostaurin for FLT3 mutated patients. And this goes on whether or not the patients did or did not have an allogeneic stem cell transplant. This again is for FLT3 mutated patients. So the question is, what about newer FLT3 inhibitors? If this worked for midostaurin, might it possibly be better for a drug like, for example, here, gilteritinib? And you can see here the schema of a trial looking at gilteritinib in combination with either idarubicin or daunorubicin to figure out what is the combination dose and schedule with standard induction therapy. And these are early data, and we don't know the answer yet, but you can see here that there are escalation and expansion cohorts already that have been reported on at this ASH, showing as a kind of top-line data that you can do this. You can, in fact, combine gilteritinib with either daunorubicin or idarubicin, and it looks like there is a quite tolerable schedule extending out from day 4 of treatment all the way through 21 days. The tolerability was what you would think, so it's a lot of cytopenias and the usual infectious complications of induction, but the conclusion of these very early data was that you can do this. You can combine gilteritinib with a high CR rate in combination with standard induction using the dose of gilteritinib that we know about, which is 120 milligrams. It doesn't matter, at least in these early data, which anthracycline you use, and this is ongoing. So which is the better agent, gilteritinib versus midostaurin? We don't know yet, and here too, there is an effort in the PRECOG trial to figure this out. You can see a 1-to-1 randomization here of gilteritinib and 7 and 3 versus midostaurin plus 7 and 3. And I think that certainly the preliminary data of feasibility and tolerability of gilteritinib look good, but is it actually better? We don't know that yet. Now, the concept here is that we want to be moving anything that is working better for subgroups of patients into the frontline setting. So looking over here, we know that venetoclax has really transformed the treatment of older patients, and I'll get to that in a minute. But the question now is, what about putting venetoclax up front? Does that make anything better? And here there are some preliminary data, both in newly diagnosed and in relapse refractory disease, showing that venetoclax plus the combination of FLAG-IDA is very potent. It's toxic, and you have to be careful. There were a lot of patients who did end up in the ICU, but it is a very high response rate regimen. And the question is that even in the relapse refractory patients, might this be a very strong bridge to transplant? So again, venetoclax is standard of care now for upfront therapy for older patients, but what about bringing it up to induction for younger patients and here in the relapse refractory setting? Now, we talk about transplant as sort of the middle of everything. We've been talking about these FLT3 patients and trying to get them to transplant. We're talking about high-risk older patients and high-risk younger patients getting intensive chemotherapy and going on to transplant. But what about patients who are older who have been getting venetoclax-based regimens as their initial therapy? Some of those patients actually do go on to transplant. They may not have been good enough shape for it at the beginning of their therapy, but ultimately they do go on to transplant. And here you can see from a year ago, from 2019, they were already reporting on post-transplant outcomes in patients who were treated initially with azacitidine and venetoclax. These are older patients, and it showed that this was feasible and that there were reasonable survival rates for patients who were going on to transplant, again, who were initially treated with low-intensity therapy. You can see here what the post-transplant outcomes look like, suggesting again that, well, maybe you don't actually need a so-called high-intensity induction for patients in order to get them to a transplant. And this actually was presented at ASH this year by Dan Pollier's group, looking again at patients who had allotransplant after ven and aza instead of getting ongoing maintenance with venetoclax and azacitidine. And here in this group of patients, they actually showed that the survival looked a bit better for those who went on to transplant versus those who had transplant deferred. There are lots of unanswered questions here. Which exact patients? How much maintenance therapy did they get? Would it matter if they got lots of post-remission maintenance with venetoclax and aza versus a little? There are lots of unanswered questions, but it certainly goes to show that induction doesn't absolutely have to be intensive in order to get to transplant, A, and B, it looks like transplant may have a role in patients who were initially considered not well enough for intensive therapy. So this leads us to a case. We have a 57-year-old patient who presents with newly diagnosed leukemia. She's got hypertension, coronary artery disease, and rheumatoid arthritis. The testing shows normal cytogenetics, a FLT3-ITD mutation with an allelic ratio of 0.2, an NPM1 mutation, and NRAS as well. So I want to toss it to my colleagues so that you guys can stop listening to my voice and say to Dr. Foran, what are you guys going to do with this patient?
Yeah, I mean, I'll tell you what we do in our practice would be to consider this person for transplant and to start a donor search relatively early, even when we're going through the induction therapy. We've been struck by the results of the ratified trial, the follow-up report that Dr. Stone and colleagues presented, showing really the long-term survival of transplant in first remission for patients who get midostaurin. And so we have felt that if somebody has a FLT3-ITD mutation, that's the right way to go. In this case, particularly with the NRAS mutation, which can be adverse or actually can be a mechanism of resistance to FLT3 inhibitors, we would bias towards transplant. Now, Dr. Robles, you make a great point, or at least built into this scenario is a great point about comorbidities. There's a person with coronary artery disease and hypertension and rheumatoid arthritis. So we're already dealing with somebody who will have a higher comorbidity score. And we know if the comorbidity score is 3 or higher on the HCT-CI, that's a situation where we pause a little bit and really try to individualize the decision.
Yeah, I mean, I think that it's controversial, and certainly if you get a lot more Europeans in the room, you get a lot more vehement responses about the low allele burden and that this patient has an NPM1 mutation, which is trackable and you can follow via PCR and you can cure some of these patients. And I think in the US, I definitely think there is a bias and kind of an ick factor, especially when you see something like an NRAS mutation to go forward with transplant. But I think for this patient, would you say it's fair as a statement, even though you're kind of fundamentally a transplanter and my heart is probably fundamentally not, so that's for the audience to know. But would you say it's a fair statement that if this 57-year-old were to have a lot of difficulty with induction, let's say she actually dropped her EF, or let's say that hypertension and coronary disease conspired against her, she had a rough induction, she looks like she's in rough shape, you're not so thrilled now about your transplant. I actually think, isn't it possible that she might be okay with a post-remission strategy that may include things like oral azacitidine or consolidation followed by oral azacitidine? We have a section where we're going to talk about maintenance. But do you think it's possible she could be cured even without a transplant?
I do. I think you're right. The low allelic ratio, the increased non-relapse mortality of transplant, and then the option of maintenance therapy. I do. This is one where you really could individualize that decision. And I like your point about NPM1 and the possibility of achieving an MRD negative complete remission. We like people to be MRD negative for transplant outcomes too, but this is a person you might cure without a transplant. The difficulty of the induction speaks both for and against transplant. And so that ends up becoming more of an individualized decision, I think.
I also think that it's worth discussion, and we'll bring this up a little bit later, so I'll defer asking you about it now, but it kind of brings up the discussion of post-transplant FLT3 maintenance. And I think that discussion sort of permeates through these meetings now, that it used to be sort of transplant was one and done. You go for a transplant for cure and then you're done. And now we have all of this discussion about, oh, but wait a minute, they're high risk. What can you do in maintenance? And let me just have you hold that thought for when we get into the maintenance section. Yeah. But for right now, I actually want to toss it to you, because it's going to be your turn now to talk to us about antibody strategies in transplant eligible AML, induction, conditioning, future applications, any possible use for antibodies. And I'm turning over this screen control to you, so I'm not going to touch anything.
Okay, thanks very much. This is the second section of our presentation, which is to talk about some of the new antibody-based strategies in the transplant-eligible patient. And the first one that we've had available for a long time is Gemtizumab Zogamycin, trade name Mylotarg, or called GO. We've known it for a long time. It was approved in 2000, withdrawn from the market in 2010, after some initial negative randomized studies did not support the accelerated approval and because of toxicity. And then it was really learned from the Alpha 701 trial that if you fractionate the dose, that you can improve the median survival. And that was in patients aged 50 to 70, as you can see. The British MRC AML-16 trial looked at a single dose of gemtizumab, 3 milligrams per meter squared in day 1 or day 4, and also showed an improved median survival. And then importantly was the Hills meta-analysis that looked over 3,000 patients that were involved in 5 randomized trials of gemtizumab. There was no improvement in the complete remission rate, but there was an overall improvement in the overall survival rate, and that was most prominent in core binding factor leukemia and to a lesser extent in the intermediate risk patients. And just you can see from that presentation on the right is the meta-analysis survival curve with or without allocation to gemtizumab. And there is a 20-point difference in the meta-analysis in overall survival. This has led to an NCCN recommendation to consider it for favorable risk AML. In the UK, it's included for all patients with AML unless they're known to have adverse risk. And among my colleagues, we commonly use it in favorable risk, more often than not at intermediate, and we don't use it in adverse risk. But this was the first antibody that has really been shown to improve outcomes. The obvious question from a transplant perspective was about veno-occlusive disease or sinusoidal obstruction syndrome with GO. The clinical experience in the original studies with monotherapy showed about a 5% rate of VOD or of SOS. With the expanded use of GO, the incidence of SOS was noted to be significantly higher and actually led to a safety concern in the first decade of this millennium, in the 2005 to 2010 era. It was identified that susceptible patients were those who'd had prior chemotherapy or who got the higher dose day 1 and day 8 schedules, and after allogeneic transplantation. I think reassuring in that regard is a subgroup analysis presented a couple of years ago at ASH, looking at post-transplant outcomes from that randomized Alpha 0701 trial among the 30% of patients who did go on to get allogeneic transplant. Now, this was an older population, aged 50 to 70, and this is the outcomes after transplant in patients who got GO in the dark blue curve versus who got control in the orange curve. And there was not a difference in survival after transplant. There was no statistical difference between those two curves. So the conclusion from this prospective study, where it was given in a fractionated fashion and where patients went on to get transplant, is that the use of gemtizumab was not associated with an excess of VOD events after transplant. There are only 3 patients who actually had a VOD, 2 of whom recovered, and it was felt that it did not increase post-transplant mortality. I'll point out that in this study, there was a recommended 60-day period from last gemtizumab exposure to transplant. It hasn't been proven that that time is necessary, but that's really been adopted as a standard based on this, this retrospective experience. Now, the next antibody that's still in development and is actively part of randomized studies is called Iomab-B. Iomab-B is a murine CD45 monoclonal antibody. CD45 is expressed on virtually all lymphocytes in the large majority of acute leukemias, both lymphoid and myeloid. Iomab-B also goes by the name of I-131 apamistamab, combines the murine anti-CD45 with the beta particle emitting radionuclide I-131, iodine I-131, targeting lymphohematopoietic cells. So it offers a target-specific ablation as part of the conditioning regimen prior to a non-ablative transplant. It's attractive in that CD45 is not expressed on other tissues, so it does not bind to normal tissues, and it directs radiation to leukemia and immune cells. As you can see, if you look at the Senegray or millicurie exposure, it's targeted on marrow and spleen and to a lesser extent liver, and very low targeting in terms of radiation dose to lung or kidney, and you can see to the total body as well when you're looking at the estimated radiation that's absorbed for all patients. The ongoing phase 3 Sierra trial is a randomized trial of Iomab-B prior to allogeneic transplant versus chemotherapy in relapsed and refractory AML. This study has reported 75% accrual outcomes. We're waiting for the study to complete. It's for older patients aged 55 or greater who've had 2 or more who are induction failure after 2 or more induction cycles of treatment, or early relapse of AML, or are refractory to a salvage regimen that includes high-dose ARC, and those in second and subsequent relapse. One of the tricky parts about this study is you have to identify a fully matched donor, an 8 out of 8 matched donor prior to randomization, either related or unrelated. Patients have to have an adequate KPS. And there's a 1-to-1 randomization to the study arm, the Iomab-B, followed by a non-ablative transplant, versus the control arm chemotherapy, which is really allowing a choice from a list of approved or available consensus regimens. Now, for those who are randomized to Iomab-B, you're committed to a myeloablative Iomab-B therapy, followed by a non-ablative conditioning regimen and allogeneic transplant, regardless of whether the patient gets a complete remission. On the control arm, if patients achieve a complete remission, which has been I'll say inadequate, but standard pathway in the past, they go on to get a reduced intensity or non-ablative transplant, followed by observation. But if they don't, they're able to cross over to the Iomab-B arm and actually get the Iomab-B therapy and the non-ablative transplant, as long as they still meet transplant eligibility. This has made it very attractive for patients with refractory AML as an option to get a standard arm and get to transplant, or cross over if they're not randomized to the Iomab-B arm. And this is how the therapy is given. There is a dosimetry phase and then a therapy dose phase of the Iomab-B. So patients get a dosimetry dose followed by biodistribution scans with imaging over a week. They then get the therapeutic dose of the Iomab-B. This is individualized to deliver a dose of 24 gray to the liver. So it takes it to liver tolerance for maximum safe liver dose for patients after the dosimetry dose. So there's some individualization of dose there. And then approximately 12 days later, patients move to allogeneic transplant. They get a non-ablative regimen using the original Seattle regimen of fludarabine and low-dose TBI. And they get standard immunosuppression with tacrolimus and with Cellcept. And these are the demographics of the study that were presented in an update at ASH, the recent ASH meetings in December, the virtual meeting, at the time of 75% enrollment. So far, 113 patients have been randomized in a 1-to-1 fashion to Iomab-B or the conventional arm. You can see that they're well balanced for the age and median age, for the cytogenetic and molecular risk, approximately balanced for the number of blasts. Actually, they're a little higher median blast number in the Iomab-B arm than the conventional care arm, although not significantly different. And you can see that the disease status at randomization was predominantly induction failure, but some with early relapse, or a relapse and then refractory at the time of relapse, or relapse after 2 regimens. The number of prior regimens was 3 regimens in this group. So this is a really difficult group of patients, or not difficult patients, but difficult disease among those patients with a median of 3 prior regimens. This also shows you the crossover arm. 30 of the patients have crossed over from conventional care to the Iomab-B arm. They had the same median age, approximately the same cytogenetic and molecular risk stratification, and about 20% blasts at that time. And 9 of these actually were randomized, had been randomized into conventional. 9 other patients actually were randomized to conventional care and transplant. Now, these are the engraftment data and the non-relapse mortality data for the patients who underwent the Iomab-B conditioning and transplant, the 47 patients, versus the 9 who actually achieved a remission with the standard therapy and went on to get a standard of care transplant. The marrow blast, you can see 26% for the Iomab-B versus 14% for those who actually achieved a complete remission with their salvage regimen. The time to neutrophil engraftment was approximately the same, a little faster, 14 days, with no incidence of graft failure with the Iomab-B, versus 17 days to neutrophil engraftment, a little longer with the standard of care transplant in one who had graft failure. Time to platelet engraftment was also favorable after the Iomab-B myeloablation and the non-ablative transplant, 18 days versus 22. And encouragingly, the 100-day non-relapse mortality was 5% in the Iomab-B arm versus 25% non-relapse mortality at 100 days for the conventional transplant for patients who achieved a complete remission. Now, 26 patients out of the group or the cohort who were randomized to standard care therapy were able to actually cross over and get the Iomab-B. And you can see that they had a similar performance in terms of time to engraftment as those who got Iomab-B and the non-ablative transplant right up front at the randomization. 14 days to neutrophil engraftment, median 19 days to platelet engraftment, and similar low, only 2 out of 24 patients, or 8%, non-relapse mortality. So if they did not achieve remission and crossed over, really had very similar, for the half of patients who were able to cross over, in the intention to treat arm, a very similar performance of the Iomab-B and the non-ablative transplant. Some additional safety findings that were recently presented. This is at 75% accrual. There were lower doses of radiation to the GI tract versus the bone marrow, as we would have hoped and as expected. And there was a low incidence of AEs of interest at the time at the 100-day post-transplant outcome. So the median marrow dose was almost 15 gray. The median GI tract dose was under 3 gray. The grade 2 to 4 mucositis was only 10%, was only 22% of patients, pardon me. The grades 3-4 fever and neutropenia was under a quarter of patients, 24%, as you can see. And only 3 patients had a clinical sepsis syndrome, which was 6.7%. So take homes from Sierra, well, this allows an individualized myeloablative dose of Iomab-B taken up to liver tolerance with radiation of marrow and of spleen and a maximum to liver. We were able to achieve high rates of allogeneic transplant on the Iomab-B arm. All patients who actually received the Iomab-B proceeded to transplant. 88% of the patients who were randomized in the intensive to treat got the Iomab-B and transplant. There were obviously some patients after randomization who fell out because of progressive disease or fall in performance status before they received their Iomab-B therapy. Only 1 in 6 patients who were randomized to the conventional arm actually achieved a remission and went on to a standard of care allogeneic transplant. And this is similar to what we had predicted in the development of the study. So a much higher rate of getting to allogeneic transplant with Iomab-B versus the standard of care. Ultimately, over 3/4 of patients, whether they were an Iomab-B or they were the standard of care and got a transplant or crossed over, were able to get to an allogeneic transplant. We saw 100% neutrophil and platelet engraftment rates after Iomab-B, despite a heavy leukemia burden. And we are looking forward to updated efficacy and safety analyses that are presented at this meeting on Wednesday, on February 10th, in abstracts 59 and 60. Now, there are other antibody-based strategies and developments. One targets Tp53 mutations. This will be a surprise to nobody. Tp53 remains a bad actor despite use of allogeneic transplant. This is a German study group, Study Alliance for Leukemia data that was published several years ago in BJH. They looked at a cohort of 97 patients who had TP53 typing. As you can see, those who had TP53 mutation had much inferior outcomes after transplant. Even raising the question about how effective transplant is in this population, many of us still believe there's a role. You can see that the median and the 1-year rates drop, and after 2 years, it's only about 10% of patients who are in ongoing survival versus 33% of the TP53 wild type. So this is a very difficult group of patients. And that's true also with venetoclax-based treatments. This is data from 2019 at ASH and also updates from 2020 at ASH, looking at the impact of venetoclax with venetoclax with low-dose ARC or with HMA based upon different mutation subgroups. It's appreciated that there are high complete remission rates with NPM1 and IDH1 and IDH2, and maybe less so with FLT3, although still respectable, but the complete remission rates seem lower with TP53. And the overall survival is significantly lower with TP53 after HMA-Ven or low-dose ARC Ven versus other genetic subtypes. So there's a lower complete remission rate compared to wild type that was statistically significant. And excuse me, and that includes also lower CR or CRI rates, significantly lower. And so we've known this. This is just prospective data telling us this, even with low intensity strategies, that that's the case. We're not presenting data on CPX351 and the liposomal daunorubicin cytarabine, but a similar phenomenon where TP53 predicts for lower complete remission rates and worse outcome. Now, CD47 is an immune checkpoint, a macrophage checkpoint. It propagates a do not eat me signal in myeloid malignancies. That's true also in AML. And it allows those leukemia blasts, in this case, to evade immune mediation by macrophages. We know that CD47 expression predicts worse prognosis in AML. You can see that in the curve on the right. And this is the signaling pathway through SIRP alpha or FC receptor or CR3 that is inhibited by expression of CD47 that inhibits phagocytosis. There have been encouraging data about the use of a CD47 targeted monoclonal antibody, humanized monoclonal, called magrolimab with azacitidine. If you look at all AML patients, the 43, at least in this presentation that David Solomon gave an update on at ASH this year in December, and also the group who had Tp53 mutation, the complete remission, the overall response rates and complete remission rates were similar when you added magrolimab to Tp53 mutant or non-Tp53 patients, suggesting that this may mitigate some of the adverse effect of Tp53. The waterfall plot on the right also shows the blast reductions in AML, including Tp53 and non-Tp53 patients. So overall, a 63% response rate, 42% complete response rate. Median time to response was similar at about just under 2 months and more rapid than we had seen in the past with AZA monotherapy. Almost 10% of patients proceeded to allogeneic transplant in this cohort of patients. And the efficacy compares favorably to monotherapy, where in the past we've seen complete remission rates closer to 20%. There are other potential advantages of magrolimab and azacitidine in newly diagnosed AML. For instance, it was observed that there was similar rates of red cell transfusion independence, that there were similar cytogenetic complete response rates, and similar rates of MRD negativity of almost 30% in the TP53 mutant patients getting magrolimab and azacitidine versus the whole cohort. And the duration of response seemed possibly better than we had seen with HMA-VEN, or at least in this study, encouraging 7.6 months in the TP53 mutant, 9.6 months in the whole cohort. And this is at a median follow-up of about 8 months, give or take. You can see the swimmer's plot looking at months on therapy by TP53 status that was encouraging. And so we're seeing high rates of transfusion independence, complete cytogenetic responses, MRD negativity, all of which are encouraging and support looking at this prospectively in newly diagnosed TP53 mutant AML. So I guess I wanted to maybe discuss a couple of cases and with Dr. Robos of different scenarios looking at antibody-based therapy. And Gail, I'll start with a fit 45-year-old man with newly diagnosed AML. He's got a moderate leukocytosis, a core binding factor leukemia with inversion 16. He has a c-KIT mutation, which is considered adverse, and receives 3 and 7 with gemtizumab for core binding factor leukemia, and then wondered, what do we do next? Is there a role for allogeneic transplant versus standard consolidation with or without gemtizumab in this patient in first remission?
Yeah, I mean, I think, people look at CBF AML and sort of, we're so happy to see something that does well in AML that we sort of jump to saying that, oh, okay, CBF is everybody's cured, except they're not. And actually, if you look at the next generation sequencing panels, there are all kinds of distribution of different mutations, which do have significant prognostic impact, both in inversion 16 and with 821's c-KIT being one of them. I think lots of people will even look at the presence of FLT3 mutations and other karyotypic abnormalities. It actually, FLT3 mutations probably wouldn't drive you to a transplant. Other karyotypic abnormalities wouldn't drive you to a transplant, but the c-KIT makes you kind of swallow hard for a second. Our practice is still, though, that we see very high rates of molecular clearance, and we do follow transcript levels by PCR in the post-remission setting. And I would say that for us, we would proceed with GEO both upfront and in consolidation. And the issue with inversion 16 in particular is that it's notable for its very, very high salvage rates, even if there is a relapse. So I still think the patient, we would try for cure in the upfront setting. We would follow very closely with PCR. There are some data suggesting, for example, that if you have a molecular relapse brewing, that hypomethylating agents like decitabine can be used to then, quote unquote, erase that MRD and then perhaps take the patient on to transplant. But we'd still try for that cure up front. How about the transplanter at heart? What
no, actually, I'm a bit nuanced. I'm a leukemia doctor and I do transplant. So I guess I'm a transplanter at heart, but I agree with everything you just said. And there are disagreements even between the Mayo Clinic sites in our cancer center, where in Rochester, they're a little more biased towards allogeneic transplant with a c-KIT mutation. Whereas if we get a high quality remission and we think it's an MRD negative remission, we'll go on with standard consolidation. And I really liked your answer about decitabine and salvage rates.
Well, I want to be nuanced too. So I want to be between transplant and leukemia too, because I think that's a good way of describing it. And I do think it's worth mentioning, though, that people get confused about what to monitor in these patients. And I would say that some of the transplanters who maybe don't do as much leukemia all the time are following c-KIT, for example. And the MRD marker here really should be following inversion 16, following the, FISH and cytogenetics, you're already too late, but you really should be following PCR for these. And it's absolutely trackable in a send-out lab if it's not done at your site. So I just wanted to get that point in, because I think what you are following in these patients with CBF who might have additional abnormalities other than just the core binding factor is very important. You want to be following the right thing.
Yeah, that's also a really important point. You raised that earlier about MRD status and following the correct marker, and that's where it really requires the transplant service and the leukemia service to be coordinating there, looking for a donor early, but also coordinating on what the marker is and how you're determining eligibility. So thank you for that. So what about a 61-year-old woman who has refractory secondary AML and a Tp53 mutation? She gets decitabine and venetoclax for 4 cycles. This is a patient where, she has a sibling donor and maybe a candidate for Iomab-B. Do you have other options or things you would do instead of a clinical trial in this situation, or what's your experience with that?
I have to say, I mean, look, my answer, and I wish everybody's answer would be that a clinical trial is kind of always the right answer in AML. That says, said it's not feasible for a lot of patients, and we certainly understand that. But this patient is the kind of perfect patient for a clinical trial, because unfortunately, this is just a really bad disease. And I would say that we're missing something still in TP53 mutated patients, because we have lots of them who are VAF negative after whatever, whether it's venetoclax or standard induction or CPX351. You can get a patient who's absolutely in CR, molecularly negative, VAF negative, go into a transplant, and they still relapse. So there is something about this disease that we're missing. And I love the idea of putting the patient onto the phase 3 Iomab if she's eligible, because I think what we want is something different from what we usually do. And that's what this clinical trial would offer. I think the preliminary data that you presented are interesting and definitely speak to the feasibility and some of the kind of preliminary good looking outcomes that they have. And I think the patient should go on to the trial. Hopefully, since was this patient at your site, the patient probably did go on to the trial then.
This patient's being registered as we speak to the clinical trial, so that's exactly what we did. I'm hoping there are other alternatives in the future, bispecific CD3-based antibodies and so on. But you're absolutely right. We need to make progress in this particular space.
I hope to see it, but I got to tell you, we are so starved for success in TP53 that unfortunately anything that looks good immediately soars. I want magrolimab to work. I want APR-246 to work. I mean, we want the drugs to work, but I think we are a bit away from showing that home run, unfortunately more than a bit away.
Yeah, and that's the third case here. This is an older patient with secondary AML and TP53. And then the question is this a person where you would ever give induction therapy, intensive therapy versus aza-ven or aza-magrolimab? And, that's going to be part of a randomized trial coming forward of aza-ven or aza-magrolimab. But this is that exact person you're talking about where there's a compelling need for an answer for this.
Yeah, I mean, we know with patients like this, I mean, you can get these patients into remission, but it lasts for a hot second. And I don't think that anybody is very excited about taking a 67-year-old through intensive chemotherapy, because it's just doesn't work well for this. It doesn't bode well for long-term outcomes. Even though you can get into remission, it just doesn't last. I think a hypomethylating-based strategy is certainly more attractive. And I would argue, actually, that one still has to demonstrate the role. Let's say this patient gets either aza-ven or aza-magrolimab. The question is, what does transplant do afterwards? Because so many of those patients still relapse. So I would love for there to be, an ongoing maintenance type of program, either with ven or with magrolimab, looking specifically for what happens combinations with TP53 patients, and I suspect that neither of those combinations is going to be alone good enough. That's where we start looking at triplets and we start looking at novel mechanisms, which you alluded to with some of the different immunotherapies, which maybe take a totally different route from the therapies that we've seen so far. But I think these are tremendous cases, actually, and I think that every single one of them is something, something that we see. These are the patients who walk through the door, and I think the antibody discussion led very well into this, but I want to take us into the third part of our story because it's AML. There's a lot to talk about. And if we go forward to maintenance strategies, so maintenance wasn't our thing, right? Maintenance was the ALL guys did maintenance, and they've shown for a long time with basically old and inexpensive and reasonably crappy drugs like things like vincristine, prednisone, et cetera, that they transformed ALL into a curable disease with maintenance. And we didn't really do that in AML. We try maintenance after intensive therapy, after non-intensive therapy, now after transplant. So what do we do with maintenance currently in 2021 for AML? So if you look at the NCCN guidelines for post-remission therapy for patients under 60, you can see that there's just a lot of stuff on this slide. So a lot of stuff usually means that we don't know what we're doing in AML, but I can say that certainly for the CBF patients, you're supposed to give HiDAC and be done with it. You're supposed to give Gemtizumab. I can even say here that we can probably spend half an hour arguing on the dose of HiDAC. Is it 12? Is it 18? Is it how many cycles? Is it 3? Is it 4? But some permutation of high-dose Ara-C plus Gemtizumab, and generally those patients are done and not getting maintenance. Whether or not they could use it, and especially the ones with challenging molecular features like the c-KIT patient, that is an open question, but it's not standard of care. For the intermediate risk patients who are under 60, they're usually getting a bunch of stuff. They're either getting consolidation, or they're getting a transplant, or they're getting a chemotherapy plus something. And then for therapy-related disease other than CBF and for other unfavorable features, what do we do? Well, you can do consolidation, but there are lots of relapses. You can do transplant if there is a transplant that is possible. But the bottom line is that we know we want to do something in the post-remission setting. These patients do not just hang out after induction. And the question is that even transplant, our best weapon against AML, we have this conversation 50 times a day with patients that this is the only potentially curative strategy. And that's true. But how often is it actually curative? And the reason for that may be leftover leukemia. And then that begs the question of what can we do even post-allo transplant with some kind of maintenance. For the older patients, I mean, these are patients who are in previous CR after intensive chemotherapy. But actually, I mean, some of them can get a transplant, some of them get consolidation. But the truth is that for patients older than 60, first of all, intensive consolidation has actually never been shown to prolong survival. So these are patients who sometimes get 2 or 3 or 4 courses of HiDAC because people are used to doing that. Doesn't necessarily or even probably prolong overall survival in patients older than 60. Some of them go to a transplant, but we presented data actually from registry data at ASH that confirm what we kind of all see, which is actually the number of patients older than 60 who really get an allogeneic transplant is incredibly low on a percentage basis. Most of these patients are not sent for transplant. There's a whole variety of reasons, including, importantly, that sometimes the patients just don't want it. They don't want a transplant. They don't want to go through it. So I think that having post-remission therapies that aren't transplant are certainly appealing, especially for older and more frail patients. So then you can see at the bottom of this trial, it says maintenance therapy. Well, what we've been doing is kind of puttering around with maintenance therapies with azacitidine, with decitabine, trying to get them to work either before transplant, after transplant, at any point where the patient is in the post-remission setting. So let's talk first about targeted therapies, because the question is if you have a target, in this case for Ratify FLT3, but frankly, we are looking for data for IDH as a target too. But can you keep going with whatever your FLT3 inhibitor? In this case, for Ratify, which was looking at midostaurin, looking here at the landmark analysis from the end of maintenance. So This RATIFY wasn't designed to specifically show in a statistically valid way that midostaurin works as a maintenance therapy. It wasn't designed to show that. But if you look at the analysis here, there is a suggestion that maintenance therapy, whether it's administered after chemotherapy alone, and there were a few patients who could not go on to transplant in RATIFY, or post-transplant, it probably does something, although it can't be proven in this trial. And I would say that many centers do use midostaurin as post-chemotherapy or post-transplant maintenance for patients with FLT3 mutations. Now, if you look over here, so sorafenib gets very maligned because it has difficult side effects for some patients, and there are definitely people who roll their eyes at sorafenib as old and are we still using that drug. I actually think it has some magical properties that are immune probably properties that we don't fully understand. But if you look at these data, they are undeniable that for patients with FLT3 mutated AML and CR after transplant, there was clearly an RFS and an OS benefit to sorafenib. So yeah, it can be a pain, you can get muscle aches, you can get weird hand-foot symptoms, but this is a drug that actually does show a survival benefit. And I think that the concept for these patients who are just definitely high risk just based on their mutational profile going into transplant, I think post-transplant maintenance is a thing. The question is, what is best? Is it midostaurin? Is it sorafenib? Is it possibly gilteritinib? Looking here at the BMT-CTN Morpho trial, gilteritinib versus placebo, which one is better? Is there any benefit, first of all, to FLT3 inhibition post-transplant? And then, of course, which one to use? I think that there are flickers in everybody's mind and from the data that something probably works here, but what exactly to use, I think, remains an open question. And I'm interested to hear your thoughts on that when we get into our cases. Now, what are the other things that we've tinkered with? So azacitidine is definitely older than I am, and we've been playing with it for a long time to try to get it to work. Here in this presentation, it actually showed that after intensive chemotherapy for older patients, the disease-free survival was better, but the overall survival wasn't better. And one of the problems with chemotherapy maintenance, which has been tried for many years, and mostly by the Germans, who really tried very, very hard to get a alternating cycles of different low-intensity chemotherapy to work a la ALL type of style, it did often show benefits in event-free survival or in disease-free survival, but not in overall survival. And basically, those benefits weren't compelling enough that the patients wanted to trek through the headache of taking long-term chemotherapy as their maintenance. But the flicker was always there that it was doing something. If you look at your stuff, now here I am presenting Dr. Foran's data, but looking at decitabine maintenance here for older patients after intensive therapy, this was from an ECOG trial. Again, there did seem to be an improvement, and in this case, an OS improvement in the investigational arm getting decitabine. But I think that in general, the data have somehow not been resounding or compelling enough that even though many of us do use ongoing hypomethylating maintenance, it's not been easy to be completely convinced about it from the published data. Now, this leads to QUASAR. So this is a phase 3 study, randomized international phase 3 study, which was presented initially at last year's ASH with updates at this year's ASH, and recently, I am very pleased to say, published in the New England Journal. But this trial actually looked at patients older than 55 who were in remission and randomized them to what was then called CC486, what is now known as oral azacitidine, for maintenance therapy for 14 days versus placebo. And then they actually just stayed on therapy with lots of follow-up assessments. And this actually did result in a survival benefit. So finally, we saw a convincing survival benefit in these patients. This has led to the approval of oral azacitidine in the United States and is felt by many, and I am biased because I participated for the last 12 years in this study, but it's considered practice changing by many because it is an overall survival benefit that's seen for AML AML patients after maintenance. But I would say that this study almost brings up more questions than it answers, because now we want to have a lot of detail about who does better and why and for how long and how exactly to use oral azacitidine. So I'm going to answer some of those. So the first part is that even in Quasar, in the study that was presented and then reported so far, which is just oral azacitidine versus placebo, the most common AEs were some GI events. They were actually mostly in the initial cycles and were pretty well managed, and nobody really stopped therapy because of them. And then the myelosuppression, which definitely can be seen, was actually not super major and was mostly seen in patients actually later in this study who might actually have had myelosuppression because their disease was relapsing. But basically, the toxicities that were GI related or myelosuppression have been relatively easily managed and did not result in patients coming off the trial. So we were gratified that people could actually stick with this for a long period of time. And I was looking back that I think I still have the patient who's been on the study longest in the United States from 2013, which is pretty great. Now, there are some updates from Quasar and ASH of 2020. I presented that oral AZA actually had consistent RFS and OS benefits regardless of the baseline MRD status. So we were very fortunate that actually the follow-up assessments included serial samples for flow cytometry analysis for serial measurements of MRD, which is the first time that this has been done prospectively in an intensively treated older patient cohort like this. And regardless of whether you were MRD positive or not at baseline, it looked like the oral AZA helped. And actually, there were some patients who did convert to MRD negative status. There's lots of discussion about those data, but it's certainly provocative. We also presented that the health-related quality of life and the low levels of fatigue, which were actually good because these patients were in remission at baseline. So AML patients, when they're in remission, they feel pretty good and they have good baseline health-related quality of life and reasonable fatigue, and they were maintained on this drug. So it was possible for you to take the drug without messing up your quality of life, as opposed to what was seen with many of the ongoing chemotherapy strategies, which were felt to be quite difficult. We also saw that in some patients who looked like they had relapsing disease, there could be escalation from a 14 to a 21-day dosing schedule with salvage of some of those patients and with reversal to remission status. So that's also an option for some patients who look like they have increasing blasts. Now, we've looked at oral azacitidine before in different settings. This was already presented in 2018, and this was looking at oral azacitidine as post-transplant maintenance. And here you can see that the overall, these are small numbers of patients, but looking at oral azacitidine in the post-transplant setting has already been shown to be feasible. The question is, who should get it? How should they get it? Should it be alone? Should it be in combination with venetoclax or with something else? Should it be in combination with a Flit3 inhibitor, with an IDH inhibitor? These are all of the kind of burning questions, and there are actually a number of clinical trials in place currently looking at oral azacitidine in the post-transplant setting with and without oral agents. And here I want to just mention, especially for a transplant audience, that oral azacitidine has substantial PK and PD differences from injectable azacitidine. It's not the same in how it performs clinically or in the dosing schedule or administration. So we do kind of have to start from scratch here and figuring out exactly how to optimize this in the post-transplant setting. So I'll just go to something, this is hot off the press just from late last year. So just to make life easy, X and the opposite of X just got presented. So there's a phase 3 randomized study of AZA versus observation after transplant in high risk and MDS and AML patients. And here there was no difference observed. But even the authors of the study didn't like the outcome of this. And they hedged by saying that, well, it didn't look like we saw anything, but more studies are needed. And I think here that it's true that the statistically significant differences weren't seen, but there were lots of reasons for that, including that the duration of post-transplant AZA was pretty short. Here, on the other side, though, if you did this combination of G-CSF and very, very low dose decitabine, this is 5 milligrams per meter squared, extremely low dose, and here they actually saw a very strong effect for the investigational arm with a significantly lower relapse rate in the decitabine arm. So this actually just, I think, underscores that we think that there is probably a role for maintenance, whether you're after chemo, whether you're after intensive chemo, low intensity chemo, or even after transplant, but we don't know exactly how to do it yet. So going to a case. So what choices can be made now in the transplant and maintenance therapy realm, given all of the uncertainty that I just alluded to? So here we have a 67-year-old with secondary AML in remission after upfront CPX351. He's got normal cytogenetics and no Flit3 or Tp53 mutations. So what are you going to do with him? So this patient, presumably, again, secondary disease, but are you going to do a transplant? What about the landmark data from CPX351 suggesting that patients actually do well after a transplant? Do you do oral AZA? Do you do something else? What are you guys doing in Florida?
Well, we would bias towards transplant, obviously, in this situation. The landmark analysis showed the ongoing survival advantage, but was particularly attractive for patients who were able to go on to allogeneic transplant. And actually getting an allo after CPX351 seemed more favorable than getting an allo after just regular 7 and 3 even. And so if there's an avenue to an allo, we would offer it to the patient. But it's a difficult tension because you're compromising your 1-year outcomes to try to get a 3-year and a 5-year outcome for that patient. And what you've just presented was how to get a better 1-year outcome and better 2-year outcome, but uncertain whether you get a better 3 or 5-year outcome with oral AZA, with CC46 versus observation. So that ends up becoming a very difficult trade-off for a 67-year-old patient. Your comment was spot on earlier that sometimes people just don't want to go through transplant, don't want to invest their life energy on that at this phase. And you have to individualize the goals in this situation for the patient. So in my mind, there's really no doubt that patient's more likely to be alive in 5 years, but I'm not sure they're more likely to be alive in 1 year or 3 years. And that becomes a really, that is not a 30-minute follow-up visit in clinic, I'll tell you that.
Tell me about it. I just had actually yesterday, it was well over an hour, a really, really hard discussion actually with a 75-year-old in perfect shape, in a great remission after venetoclax and azacitidine. How does one make this decision? So again, you get back to the statement is there. The only potentially curative option for transplant is an allo transplant. But okay, this patient is 67. If you take a patient who's 75, how many patients who get allo transplant are actually cured the way they think of cured? Like 5 years, I feel perfect. I'm doing the same thing. I'm now 80. I'm in perfect shape. I don't feel like that's a super big number.
Yeah, you're right. That's where, the emerging concept of Griffiths, the GVHD and relapse-free survival is increasingly important, I think, particularly in this older population. Who are the group who really get what you just asked for? Not only cure, but quality of life and don't get chronic GVHD and have what they want. And I think we need more information on really what the Griffiths is in this population to help with that. That's a really tricky one.
I think the debate also, when you look at this number of sort of, okay, we didn't have a lot of people getting to 2 years at all, actually, in older patients with AML, and now we do. So the question is, for some patients, I think, okay, if I am taking intensive chemotherapy followed by oral azacitidine, or if I am taking azacitidine combined with venetoclax and I can get to 2 years, am I definitely willing to take the upfront risks of transplant, or perhaps risking 1 year of feeling crummy in order to get to the second year? I actually think these are pretty gut-wrenching discussions right now. But would you agree that transplant is looking right now, like for many groups of AML patients, I won't say all, but for many, there might actually be a role of post-transplant maintenance with something?
Oh, it's got to be. It's the biggest question we have. You're right. I liked your comments on the SORMAIN trial. And I also like how you highlighted the oral azacitidine differences in those last two papers. It's really not the same thing, and we need to know that answer. Relapse is the biggest problem after transplant still. So we definitely need better post-remission or post-transplant consolidation therapies or maintenance therapies. There's no doubt.
Well, listen, I don't want to risk my life, but I guess I'm virtual, so nobody can come and get me. But for me to end a meeting at a transplant conference by saying that transplant might not be the only thing that you need to do for AML, I feel like that'll be hazardous to my health. But I do think that there are novel therapies in AML have changed the practice of AML. It is more fun now. We are doing better with more patients. But some of these novel therapies actually are creeping into transplant land because both before, during, and potentially after transplant, these patients actually may benefit from ongoing therapy. I never thought I would think of AML as hypertension, where you have to take a drug forever, but it might be the case that ongoing therapy, even for patients post-allo transplant, is a good thing. I'd like to thank you so much for what I think has been a great and fun discussion, and to thank the audience, and please encourage the audience to visit us at peerview.com. Thank you very much.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UPA860. This activity is supported through educational grants from Actinium Pharmaceuticals, Astellas Pharma Global Development Incorporated, Bristol Myers Squibb, and Gilead Sciences Incorporated.